everyone, and welcome to our live event tonight. It's a Tuesday evening, so I'm glad to be back with all of you, and I hope you will find it very, very useful. There are plenty of topics we have done in the past, but as you know, this year we are continuing with some more topics again, and we are inviting lots and lots of experts. Try to bring you as many interesting topics as we can, simply because we want to support you. And let me just briefly tell you that myivfences.com, we are part of European Fertility Society, and all those webinars are brought to you simply because we want to educate you. We want to answer any of your questions, but also we want to invite top fertility experts to help you out on your journey. We know it's not an easy one, so we are happy that we are here. And as always, we are very happy and excited that we have another special guest. If you've seen our previous webinars last year, you know Dr. Halyna has been with us before. And Dr. Halyna Strelko is right here. Hi, Dr. Halyna. Welcome back. And how are you feeling tonight?
Evening. Nice to see you again. This is my first webinar this year. Unfortunately, it is not very good political situation, but I hope it will be better. And I am very happy that all European people support us. And I try to present very, very interesting topic this evening.
Perfect.
And as for me, it is one of the most interesting topics. So hope you will ask a lot of questions.
Yeah, we are definitely
I will
looking
try
forward.
to answer all of them.
Perfect. Thank you so much. And let me just remind everyone that, of course, we will start with the presentation on our topic. We will talk about stimulation protocols, and Dr. Halyna will explain all the details during her presentation. But afterwards, your time will be also there, so you can ask any questions that you might have. And as Dr. Halyna has said, she will definitely try to help you out as much as possible. This is being recorded, so of course you will be able to find it on our website tomorrow. And let me just add that Dr. Halyna is the co-founder, but also leading fertility specialist at IVMED, located in Kiev, and we are definitely supporting you. And we are happy that you are right here. And I guess we can go ahead with our presentation. I'm sure you are all ready and want to see what Dr. Halyna has prepared for all of you. So, ready?
Yeah, sure.
Perfect.
So
Let's go ahead.
we will
Thank you so much.
Let's go.
Let's go.
Okay, so our topics this evening is controlled ovarian stimulation. What can go wrong? What can be not as we expected? And unfortunately, it is quite often that we receive the result which were not expected. So, what is the main goal of controlled ovarian stimulation? We know statistics say that only 23% of all embryo transfers finish to delivery. Yeah. And it is a big data from 38 countries and 1,169 clinics in Europe. So the main goal of controlled ovarian stimulation is to harvest enough eggs with as minimum acceptable quality, and better to have good quality, which can permit to obtain live births. Important question is quality of oocytes. And this quality depends on woman age and also maybe individual pattern. And generally, we need more eggs with increased age. So, how many eggs is considered as good number? As I say, it depends on woman age, and you can see in this graph that, for example, if woman has less than 35 years old, or like comparing group as young girls donors, to have 50% of chance to receive pregnancy, necessary to have approximately 7-8 eggs. But if woman has 40 years old, the same chance she will have with around 20 eggs. And if she has 43 years old, it is around 50x. Yeah, it is huge number, and normally in this age we have no such number. But this graph show that more pronounced reproductive age we have, more eggs we should receive to have acceptable pregnancy rate. Also, to understand if something go wrong, we should understand what is the normal response. Yeah. So, as we have seen, around 10 till 20 eggs with the age before 40 years old permit us to have as minimum 50% probability to have live birth in most of case. Yeah. And the number of eggs during controlled ovarian stimulation, of course, we cannot receive like that. We decide to receive and oops, we have all our eggs. It is not like that, unfortunately. The number of eggs depends on protocol, depends on anti-Mullerian hormone, body mass index, medication dosage, sensitivity, and a lot of other things. In this slide, you can see how many protocols described now. We know we can use all of these protocols, and normally we use all of them. Yeah, it is short protocol, it is classical short antagonist protocol, long protocol, short agonist protocol, protocol from luteal phase, natural cycle, mild stimulation, flare-up protocol, stop protocol. So a lot of protocols. And of course, necessary to understand the, how to say, principles, mechanisms. And in this case, you will easily understand, is it the good protocol, or it was bad protocol, or it was some problem which is not related to protocol. And we will try to see what kind of problems we can have during the ovarian stimulation. So what can go wrong? It may be excess response. We can expect this excess response. We call this response like ovarian hyperstimulation syndrome. Yeah, and we expect this when our anti-Mullerian hormone is more than 3.5 normally. But sometimes we can have non-expected ovarian hyperstimulation syndrome. And normally when we have not very high ovarian reserve, but anyway, we can have ovarian hyperstimulation syndrome even in natural cycle. It is rare, but we can have. Also, we can have poor egg quality. It may be expected, as we have mentioned, mostly depend on age of woman. After 38, 40, unfortunately, more often we can have eggs with not very good quality. But sometimes we can have poor quality of eggs in young age. And it may depends also on protocol or some mistakes, and we will see later exactly. And also, sometimes we can have poor response. Yeah, it is expected when IMH is quite low, less than 1, but sometimes it may be also with normal IMH and with young age, and also we will see when it may happen. So, normal IMH, what is it? Around 15 years ago, there was the normal range of IMH, but now the laboratories say that if you have less than, it is, how to say, for such age is okay, and if you have more than, it is like excess. But generally, you can see in this slide, if we have less than 1 nanogram per milliliter, we can expect the reduced response to stimulation. Why there is normal range? Because if, for example, you have 1 nanogram per milliliter, for example, at 25 years old, of course, it is not good. But if you have the same number at 45 years old, it's good, it's normal, because it is normal age of menopause. So the normal range of IMH depends on age mostly. But if we are talking about ovarian response, also we can see this, how to say, classification, yeah, that less than 1 it is not good, less than 0.1, 0.2 it is absolutely not good. From 1 till 2.5 it is considered as normal response in most of case. More than 2.5 it is very good response. More than 3.5 in most of case we have the risk of ovarian hyperstimulation syndrome, and more than 5 quite often it is polycystic ovarian syndrome. Also, we can look on antral follicular number, and also we can see that if we have low ovarian follicle number, we can expect to have poor response, and if we have a lot, so we can expect good response to ovarian hyperstimulation syndrome. Why ovarian hyperstimulation syndrome? It is really the problem of the protocol, because the ovarian hyperstimulation syndrome is triggered by exogenous administration of HCG, human chorionic gonadotrophin. There are two main medicine to produce the final egg maturation. It is HCG, like Ovitrel, for example, or Pregnil. And this molecule is look like LH, luteinization hormone, and activate the same receptors, but this molecule stay in your body around 10 days and has also what we call FSH-like effect. It means that act like a follicular stimulation hormone, and during all these 10 days, this molecule continue to stimulate your ovary. Not only maturate eggs, which we take out during the egg collection, but also continue to stimulate. And that's why it is produce all these symptoms of ovarian hyperstimulation syndrome. Whatever response you have, without HCG, the probability to have the real ovarian hyperstimulation syndrome is mostly zero. So this is the real complication of the stimulation protocol. The main question is the prevention of ovarian hyperstimulation syndrome. How can we prevent this? Yeah. When we use HCG, the risk to have quite heavy ovarian hyperstimulation syndrome is more than 5%. And if we change only one medicine, we use agonists for final egg maturation, we will have less than 2%. So you can see that it is quite big difference. And severe ovarian hyperstimulation syndrome never occur without pregnancy. It means that if during the protocol of stimulation you will freeze all your embryos or all your oocytes, for sure you will not have transfer and you will not have pregnancy in the same cycle. So you will never have heavy ovarian hyperstimulation syndrome. Also, another kind of prophylaxis, it is the short protocol of stimulation with antagonists. Also, different studies show that only use of this protocol instead on classical protocol may decrease the probability of OHSS significantly, as you can see. Second, the main prophylaxis of ovarian hyperstimulation syndrome is the use the agonists as a triggering of final egg maturation, as we have said. And in this work, it is quite recent work, published in 2021. You can see that with good number of oocytes, two groups of agonists and groups of Hcg, yeah. Good response, around 20, 21 oocyte. We can see that with agonists, 0.5 the probability of ovarian hyperstimulation syndrome, so mostly zero. And with Hcg in this group of women, we have mostly one half with the symptoms of ovarian hyperstimulation syndrome. So, agonist trigger and freeze-all strategy, it is the main instrument to prevent ovarian hyperstimulation syndrome. And without Hcg triggering, the probability of this complication is mostly nil. So, to avoid this kind of problem, necessary to identify the patient of high risk. It means that in OHSS in previous protocol, young age, high IMH level, stimulation protocol should be with antagonists, trigger should be agonists like diferilin, for example, or decapeptyl. Necessary to use the minimal dosage of FSH for the stimulation, but even with high response, even if we have 30, 40 follicles with agonist triggering, we will never have ovarian hyperstimulation syndrome. And of course, necessary to exclude the pregnancy in this case, so to choose the freeze-all strategy. Okay, so what about egg quality? So as we have mentioned, egg quality, of course, it is individual, but depends on woman's age. This is the statement of ISRM, American Society for Reproductive Medicine, and it is written that after 35 years old, unfortunately, quality of eggs and pregnancy rates start to decline. Mostly, it is related on maternal meiotic abnormality. It means that quality of eggs, yeah. Because we can see that if we calculate the part of each parent of inside of, if we calculate the probability to have genetic abnormality of embryo and can see if it is related on woman or man chromosomes and eggs and sperm, we can see that mostly with the age of woman, we can increase the probability of genetic abnormality. Paternal age is not so directly related, and mitotic, the percentage of mitotic abnormality is mostly the same in all ages. So main problem is unfortunately woman's age. The why? Because with the age, the number and quality of mitochondria decrease dramatically due to some damages, and as we know, mitochondria, it is the main battery of egg. And when we have the decrease in number and quality of this mitochondria, we have less potential to fertilization, cleavage, and so on. Another factors may be also involved in this process, shortening of the telomere, coenzyme dysfunction, spindle degradation and abnormality, and it is increased the number of genetically abnormal eggs. And in this case, we will have low egg quality, but how to say, it is more or less predictable. The prognosis of potential response of on controlled ovarian stimulation is mostly based on anti-Mullerian hormone and antral follicular count. And both parameters are not very stable. Now we will talking about protocol of stimulation because, okay, with age it is more or less easy to understand. With hyperstimulation also we can deal quite easily. So the main question when our stimulation is go not very good. Yeah, we expect to have good prognosis. We have good number of antral follicles. We have young age. We have good level of IMH, and oops, we have only one egg. So why? Uh, let's see the anti-Mullerian hormone a little bit more. So we have a lot of mechanism of discordance between ovarian response and IMH level, which we have measured, because we can see that follicular IMH and IMH which we receive from lab, it is maybe two different numbers. Yeah, why? Because we have different sources of variability of IMH. For example, it may be some systemic problem like physiological, like day of cycle. Also, it may be pathological problem like some tumors, some abnormalities. Also, it may be administration of some hormonal medication like estrogens, like progesterones, like contraceptive pills during ovarian stimulation also. Uh, Also, it may be some pre-analytic variations, like temperature, when tube with your blood stay before this blood is taken for the analysis. Or also, it may be some preparation protocols which are not correct. Also, it may be freezing and thawing of blood or plasma before you will do this, laboratory will do this analysis. And also, it may be some analytical variability due to kind of machines, kind of reagents, and so on. And in this case, we will have some level of IMH in blood circulation, but we will receive another number in your analysis, and it may be quite big difference in these two numbers. Okay, let's talk about physiological variability. So we can see the different patients, different color is different patients, yeah. And during the menstrual cycle, they has done IMH level measurement in different every 7 days, yeah, at the beginning and the end, in the middle, and so on. And you can see that some patients has quite stable level of IMH, but some patients has very big difference in different phase of cycle. It may be due to waves of follicle growing. It means that follicles growing by some cohorts. And it may be that in some period of cycle you have more antral follicular or less antral follicles. Also, it may be due to this problem that we have mentioned before. So it is quite often, and the difference in the same cycle may reach 20-30%. Also, if women take oral contraceptive pills, it may decrease the level of IMH till 30%. Also, pregnancy may decrease, ovarian tumors may increase IMH level, surgical interventions also, and also some treatment like chemoradiotherapy. It means that if we receive IMH level, which permit to prognose the good response or bad response, 30% of case our prognosis may be not so correct. And it is not because, how to say, protocol was wrong, dosage was wrong, doctor was not, how to say, very professional. It is because if our prognosis only has made on IMH level, due to IMH variability, our prognosis may be not very correct. Okay, last table about IMH validation. Okay, it is very little letters, but all these works mentioned in this table show that different conditions may change IMH level dramatically. For example, effect of long-term storage with minus 20, IMH level is may increase to 130%. Yeah, it means that if at the beginning you has real number 1, you will receive like 3, and after with low dose stimulation protocol you will receive 2 follicle, and it will be of course big problem. Or, for example, dilution previous to made the analysis, or use some specific reagents. Okay, we will not discuss all these technical things, but you can see that quite a lot of things may influence the IMH level, and it may change really the final result. So necessary to know that. And for example, if your doctor see that you have good follicle number and you receive bad IMH or just opposite, probably necessary to change laboratory and repeat the analysis once more. Okay, let's move. Unexpected low ovarian response. This is the more often problem that we discuss with our patients, because, okay, if you expect to have a 5 eggs and receive 10, it is okay, it is good. In most of case, doctors and patients are happy. But if you expect to have 10 and receive 3, this is a problem. So there is a Poseidon consensus, the group of doctors who was involved in low ovarian reserve patients scientific investigations, divide these patients in 4 groups. This is this classification named Poseidon group, and there is 2 first group when young patients less than 35 years old and older patients more than 35 years old with good IMH level has low response to normal standard stimulation. And why we can have this kind of problem? Quite often, unfortunately, it may be due to mutation of FSH receptors. And in this case, this woman may have delay of puberty, decreased breast development, sometimes primary amenorrhea, but sometimes they have not good response to stimulation. Also maybe FSH receptor gene variant, also maybe LH receptor mutation, also maybe polymorphism of FSH and LH, and also polymorphism of their receptions. So it is a lot of mutations and polymorphism were described. Quite difficult to know about that before. And even if we suspect we should do 10 or 20 different genetic tests, it is quite difficult from practical point of view. Not all laboratory accept this kind of test. But from the other hand, we should know that sometimes it is not related to bad protocol or bad product or something else, because sometimes patients say that, okay, I have bad response, for example, with Puregon, let's change to Gonalev. Okay, we can change, but Probably it is maybe due to this kind of things and not to, for example, Puregon or Gonalev. Yeah. So quite often, unfortunately, it is some real problem and not the problem of bad protocol. So, what to do in this case? The recommendation of this Poseidon group, subgroup 1 and 2 patients with normal AMH level and unfortunately bad response, is to increase the dose of FSH, add LH to stimulation, add growth hormone, to use what we call double or dual triggering. And sometime we propose the programs of egg banking. It means that we collect eggs in several cycles or 2-3 times and then use all of them for fertilization. And also sometimes we can use advanced embryological techniques for egg maturation, for working with these eggs to improve the probability of fertilization and cleavage. Okay, also very upset situation when we have unexpected low egg quality and maturity. It may be due to protocols, to products, to dosage, but quite often it may be due to triggering, to last injection. The premature ovulation, also it may be the problem of triggering. It means that the triggering was proposed to do later. Normally it is 3-4%, but in some group of patients it may be quite often. If we have not sufficient maturity of oocytes, more than 50% of immature eggs, normally should be 75% or more M2 eggs, mature eggs. But if we have less than 50, it means that something wrong, or it is premature trigger, or it is insufficient dose, or it is not good type of triggering, because we have mentioned that there is two type of triggering. Sometimes we have post-mature oocytes, it means late triggering, and we have what we call empty follicle syndrome, uh, so no eggs at all. A real empty follicle syndrome, it is very, very, very rare condition, and in most of case also it is due to not appropriate triggering. So, empty follicle syndrome. Uh, real frequency is much less than mentioned, probably 0.2, 0.1%, but we can see in clinical practice much more often because a lot of what we say empty follicle syndrome due to some errors, mistakes, and mostly triggering mistakes. Trigger not done correctly, not done in good time, so mostly this 67%. And also maybe the real problem of maturity. Also maybe what we call suboptimal response to agonist triggering. Also low maturity rate, low fertilization rate, cleavage arrest, low blastulation rate. Normally should be around 40% as minimum blastulation rate and low pregnancy rate. So why it is the problem low maturity rate? Because nucleus and cytoplasm should be maturate at the same time, but this is two different processes. And when we have a lot of not mature eggs, probably some part of eggs which we consider as mature has immature cytoplasm. And in this case, we will have the problem with fertilization, cleavage, and so on. And statistics and scientific works show that when we have low maturity rates, even eggs which we consider as good, as mature, normally give less fertilization and less cleavage and less quality. Risk factor for suboptimal response to gonadotrophin-releasing hormone agonist triggering. Uh, it is the contraceptive pills. Yeah, it is really maybe the problem, because the main problem when we can expect this not adequate response to agonist triggering, it is very low LH level, luteinization hormone level. And this is low LH level may be some inner condition, but quite often may occur when women take oral contraceptive pills during long period. And till 25% of women with low basic LH may have not adequate response to agonist triggering. And if before it was very often that before IVF treatment, doctors proposed to take during couple of months the contraceptive pills, now it is changing. Now, in most of case, we can start stimulation any day of cycle, and no need anymore to take these pills during 2-3 months and decrease your LH dramatically. So, also, what can we have as a problem producing suboptimal response to triggering? It may be some inner condition like early oocyte atresia due to follicular genesis dysfunction. It may be mutation of receptors to LH or Hcg. It may be some abnormal activity of some medication. It may be also increased hepatic Hcg clearance. It means that body more quickly destroy this Hcg. And also maybe very low LH level at the beginning of the stimulation. We have talking that it may be due also to taking contraceptive pills. And also, unfortunately, quite often maybe some mistakes during the administration of medication, especially self-administration. And for example, as little like even I don't know, anecdote example, we have a patient who has done during 7 days injections of some medication, and after 7 days we discovered that no response at all. And when we start to asking her how she is doing her injections, we discover that she don't put needle, and she put like syringe without needle, and of course no medication passing her blood circulation. So a lot of things may be wrong, unfortunately, and should be very attentive doctors and patients to understand that. uh, so if trigger injection was not made or made incorrectly, how we can check that? The next day after trigger injection, after 8-12 hours, we can do the ovulation test. If it is positive, it means that your LH level is high and all is fine. But if it is low, it means that or this medication doesn't act or you has done not correctly. And we can repeat the new triggering. So it is the good method to control. Also, this immaturity, which can be even with normal response, can be due to body mass index and also total dosage of stimulation. So, in patients with very high dosage of stimulation, this problem of maturity occur quite 4-5 times more often than in patient with normal response. also patients with very low body mass index, and also patients with low basic LH level more often can have not good response to the triggering, agonist triggering. This very difficult table show that sometimes, unfortunately, oocyte maturation failure can be due to some inner inherited genetic problem. We will not discuss all these difficult things, but you can see that there is a lot of some mutations and mistakes which are hereditary, which we cannot change with some stimulation protocol, with some triggering, with some medication, with some treatment, that it is some inner problem, and sometimes, unfortunately, it is not due to protocol, and necessary to know that. So, when we have not good maturity of oocytes, what we can do? This is the how to say scam, how we can deal with that. For example, if our patient is poor responder, we can do what we call double triggering. It means they use at the same time Hcg and agonists. If we have normal response, we can do the same. It may increase the number of mature eggs. The difference between these poor responders and normal responders, that for poor responders, we have more risk of premature ovulation. So will be good to do that a little bit later. It means less hours before the egg retrieval, around 34 hours. And third category, it is abnormal oocytes maturation. In this case, we can have agonists 40 hours before the egg retrieval and Hcg 34 hours. It permits us to stimulate LH receptors more time, more hours. And sometimes it is really improve the number of mature eggs. Okay, so our treatment options in case on not good egg maturation, dual or double triggering. Also necessary to control LH 12 hours after agonists of GnRH triggering, and discover in this moment if LH level after triggering is not good, and probably repeat the triggering or change to Hcg. Also very important to discover all kind of mistakes, errors, or some problems, technical problems. If mistake is found, will be good to repeat the triggering as well. And also necessary to have advanced embryological techniques and approaches to all sides of not good maturity and not good quality. And as a conclusion, I would like to say that theoretically we can divide the poor results in two big categories: expected poor prognosis and unexpected poor prognosis. Unexpected may be due to some objective patterns like receptor mutations, genetic problem, uh, age, and whatever we will do we will not change a lot. Some problems of controlled ovarian stimulation we can improve and resolve by dose changing, by some supplements addition, by change of our trigger final injection, by using advanced embryological techniques. And very important to avoid mistakes, because quite a lot of problem may be due to some simple technical mistakes and errors. So I finished my presentation. Now I'm waiting for the questions. Thank you for your kind attention. Hope it was not very difficult.
Brilliant as always. Thank you so much for that brilliant presentation. Lots and lots of details, but as always, you have been very thorough with explaining. And one of the patient even said that wasn't aware that there are so many protocols available. So I'm glad that it's helping already. And thank you so much, everyone, for your questions, because I'm not sure if you see, Dr. Halyna, but there are
Yeah, I
plenty of
see, but
questions.
only one by one. I cannot
Of course,
move,
don't worry. I will show them
this
to
is
you one
there.
by one. So just give me a second and let's start our Q&A session. Okay?
Okay, I am waiting.
Perfect. So here's the first question from Fran. Those three, sorry, this is actually also the comment, right? So natural, short, and long have been offered. I believe it is my daughter-in-law's choice. But is there a recommended protocol for 35-year-old with ICSI about to start a new round, last 3 rounds of egg collection? And just give me a second. There are some additional information here. Correction. Okay, 19 eggs between 7, 9 embryos.
Okay. Probably I don't understand well the question. I will repeat. If I understand not correctly, you will how to say,
Exactly,
correct
Fran,
or
you
right.
can go ahead and
So,
type anything, of
as
course.
I
Go ahead.
understand, the question is which is the best protocol for 35 years old woman with ICSI. And the previous protocol showed that quite big number of eggs and around 7, 8 embryos, right? So the necessary necessary to know the quality of embryos and quality of eggs, and after that decide which protocol will be better. Why? Because if we receive, for example, 19 eggs, but one half was not mature or degenerated or something like that, it is one question. Another question, if all 19 was good and not fertilized. And the third question, if all was fertilized and not go till blastocyst stage. So if we have more than 25% of M1, it means not mature eggs, we can try something like double triggering, like Hcg triggering, like probably growth hormone. We can prolong the stimulation and try to achieve more mature eggs. But if, for example, we have one half of degenerated eggs, this will not change a lot. If we have post-mature eggs, probably necessary to do the triggering earlier. So there is no protocol better for 35 or better for 40 years old. Necessary to see the exact condition and exact eggs and embryo quality. Normally, the standard recommendation after 35 years old is to adding luteinization hormone or urinary like Menopure or like recombinant Pergoveris, something like that. It may improve the quality and quantity. Also, some authors recommend for such category of patients add growth hormone. Also, it may improve the number and quality. In most of case, long protocol, how to say, there is no benefits because with big number of eggs, this is the risk of ovarian hyperstimulation syndrome. Why? Because in long protocol, we can use only one type of triggering, Hcg. And Hcg, as we know, produce ovarian hyperstimulation syndrome. So for poor responders, long protocol probably it is not good option because first we should do the suppression and then we should do the stimulation. And when we have very suppressed ovarian reserve, after this suppression, we can have very poor response. If we have good reserve, we will receive good response, but at the end we should do Hcg, and Hcg will produce ovarian hyperstimulation syndrome. So long protocol now this is a big question when to use.
Okay, thank you. I just want you to see that Fran has added a few things. Yeah, in the last round, there were 5 embryos, 2 transferred, and went to live birth, 3 frozen, 2 have failed, and 1 is left. It's from the
Uh,
very same patient, of course. Yeah.
One embryo is left. Yeah?
Yes. Mm-hmm.
It's good. Good. Normally, there is a recommendation of how to say normal embryological laboratory work and excellent laboratory work. It is published in articles you can find if you want. So, if you have as minimum 40% of blastulation, it is considered as quite good result. It means that if you have 10 eggs, for example, 8 fertilized, because fertilization should be around 80%, till blastocyst stage, you should have as minimum 3 embryo, and it is considered as normal because around 40-50% of all eggs at age 35 years old may be genetically abnormal, but it is generally, but individually it may be 30%, but maybe also 60%. So if egg is genetically abnormal, will not fertilize and will not go till blastocyst, unfortunately.
Okay, sorry, one
Yeah.
more from Fran. Okay, but for
Okay.
this new ICSI, yeah, which protocol is best?
As for me, better to use the short protocol because we can use in this case double triggering. We can use Hcg and then we can use also agonists. With long protocol, we cannot use agonists as triggering. And also necessary to know the maturity of eggs during the protocol. So quite like that, it is difficult to say exactly. Necessary to see the previous dosage, to know the body mass index, to see the duration of stimulation. Normally, we are using in our clinic or urinary gonadotrophins after 35 years old, or using recombinant LH like Perboveris, and also using double triggering. And sometime when we can see that number of antral follicles are good, but they are not growing very well, we can add growth hormone. So like that.
All right, understood. Of course, perfect. Thank you so much, Fran, for your questions, your follow-ups as well. And as you can see, there's a thank you from Fran for you.
Yeah.
Okay, let's have a look. More
Yeah.
questions are coming in. So here's the next one. For low AMH, does DHEA help increase AMH and allows better outcome, or does it further reduce the egg reserve?
Very good question. Thank you. There is different publications about the hair. Yeah. Some of them, it was around 10, 12 years ago. It was the boom of hair. Yeah. It was written that now we resolve all the problem of poor ovarian reserve. We take hair and all will be fine. And really, in some publications, we can show that and we can see that the number of antral follicles increasing after 2-3 months of hair. But from the another hand, it may change this antral follicle number. It may change without any treatment. Cycle to cycle variability, as we have seen, is around 30%, maybe till 30%. So even without any treatment, time to time we can have better number of eggs, and time to time we can have less eggs. After hair, it was seen that transdermal testosterone also may be helpful, and more recent publications show that it works even better than hair. Uh, it may increase, both of them may increase IMH level, but not per se, because these two molecules, they, how to say, decrease the atresia of antral follicles, because every month around 1000 of antral follicles start to grow in, and then decrease, go to atresia, and after 12 weeks around, we have at the beginning of cycle some amount of the central follicles which are ready to grow in. And these little follicles produce IMH, anti-Mullerian hormone. And when we use this kind of medication, like hair, like transdermal testosterone, we may decrease a little bit this atresia. And in this case, we will receive a little bit more antral follicles and a little bit more IMH level. And it may improve outcome, of course. The problem that big RCT does not show the dramatic improvement because, okay, if you have, for example, 1 egg more, and before you have in your protocol 8 eggs, and after hair taken you have 9, it will not change a lot the result, the live birth rate. But if you have, for example, in previous protocol 1 egg or 2 egg, in 2-3 months of this treatment you receive 3-4, only in this case probably you will have statistically significant difference, but it is quite difficult to find enough patient to correct scientific work, yeah. And that's why little amount of, how to say, little study in some group of patients show the benefit, but big RCT unfortunately not show the big difference.
Thank you so much for yet another question. And actually, one more from the very same patient here. Can you do stimulation and freeze egg back to back, or do you have to have a break between cycles?
Look, it depends because in some cases, when patients, how to say, hurry up, for example, especially foreign patients come to our clinic, they cannot stay 3 months or 5 months. So we are doing in this case 2 consecutive stimulation in 1 cycle. And second stimulation sometimes work even better than first one. So I try to find some recommendations that necessary to wait 2 months, 3 months, and sincerely speaking, I don't found such recommendations. Only if you have very high response, probably necessary to wait into 3 months when the corpus luteum in your ovary resolve, yeah, and it take 2-3 months. But if you have normal response, there is no some scientifically proof recommendation to wait some amount of time, yeah.
Understood. Thank you so much for that.
So depends on what you would like to do and how many time do you have for that.
Of course. Thank you. And let me have a look. Okay, Irina has another question here. I'm 40 and my MIT 0.033. Which kind of protocol would you recommend, or would you recommend to go to egg donation?
Yeah, thank you for your question. And question is quite interesting because IMH level 0.03. It means that it is mostly 0. But from the other hand, if we have seen that it may change. In some cycles, you can have 1 follicle, in some cycles 0, in some cycles 2, for example. So necessary to follow your cycles. Second point, that it may be the problem of laboratory. Some machines to measuring IMH, they have different threshold of sensitivity. So for some laboratory, they can show this level, and some laboratory, it is below the level of sensitivity of machine, and they will give this result, but finally it means nothing because probably IMH level is a little bit higher. So necessary to see ovary. by ultrasound. If there is one or two antral follicles, of course, necessary to try to catch them. But stimulation in this case is mostly useless because stimulation will not produce more follicles. If you have such IMH level, it means that you have one, probably two follicles. They will grow in with stimulation or without stimulation. So in this case, probably natural cycle will be the best option. And probably kind of pretreatment like coenzyme, like THEA, like testosterone, sometime replacement hormonal therapy may be useful. So something like that. And looking every month and searching antral follicles, following them and trying to catch in natural cycle.
All right. Thank you for yet another question and advice here. Let's have a look. Okay, there will be another question from the very same patient. There are like three parts of that. Okay, let me just go to
Okay.
here. So I'm 43. I will have an IVF with egg donation. I have a blood disease. What will be the most appropriate protocol in my case to facilitate the implantation of embryos? And I have a genetic mutation with secondary amenorrhea since 35 years.
Mhm.
And one more thing with COVID, I started this year and they recommend to take estrogen. Normally, I will do the transfer in April, 11th of April.
Okay, thank you for the question. Will be good to know about the blood disease because it is increased coagulation or decreased. It is different. If it is increased, necessary to give something like heparin, like aspirin, and if it is some opposite problem, okay, necessary to do the specific treatment. So like that, difficult to say. Sorry. Uh, Second part of question is about estrogens. Yeah, if it is premature ovarian failure, normally before to do the transfer, uh, will be good to preparing endometrium and uterus to give the to replacement hormonal therapy for 2-3 months. First, to see if endometrium respond well, and second, to improve the blood circulation and endometrium growing. And if all is fine, of course, preparing uterus to the transfer. And about COVID, okay, with COVID, it is another story. After COVID, during 2-3 months, sometimes we have some changes in blood. In some patients, we have very low thrombocytes level. In some patients, increase. In some patients, we have coagulation problems. So necessary to see case by case. And normally we are waiting 2-3 months till the moment when the blood parameters will normalize or give some treatment if it is not arrived by itself.
Thank you, Maria, for your questions here, and I hope that was helpful. And let's have a look. Another question from Natalia. Do you use estrogen priming in order to synchronize follicles in advanced maternal age patients? When in cycle do you start and for how long?
Yeah, thank you for the very interesting questions. There are a lot of strategy to synchronize the cohort of follicles. Long protocol, this is the one of strategy. Why sometime for poor responders propose to use the long protocol? Because they switch off ovary and try to synchronize follicles. Also, we can do that with estrogens because high estrogen level will decrease FSH level, and we know that FSH level change during the cycle. There is the first wave in the first part of cycle and second wave after ovulation before the next menstruation. And when we add estrogens, we decrease the second wave, and that's why follicles stay, how to say, more or less stable size. So yeah, time to time I am use that. Also, we can start the stimulation in second phase of cycle. If, for example, in 19 or 20 days, we can see that all follicles are more or less the equal size, no need to wait the beginning of cycle, and we can start immediately. So there are a different strategy. We can use also antagonist injection in this moment. How long? How long? 5, 7 days, around 1 week. It is enough in most of case.
Understood. Thank you so much indeed. And next question, another interesting one. Why do FSH regimes lead to a good amount of eggs but few blastocysts compared to regimes with FSH and LH?
Excellent question. Thank you very much. Uh, it is not always lead to low blastocyst number. In some category of patients, it may happen. Age more than 35 years old, some LH receptor mutations, and some problems with basic low LH, like after contraceptive pills. In normal physiological cycle, FSH increase at the beginning of cycle, and when follicles start to grow, produce estrogen, FSH drop down. But LH start to increase. So the second part of follicle growing, follicle are more sensitive to LH than to FSH and need more LH than FSH finally. So to normal egg maturation and normal follicle growing, we need not only FSH but also LH. When woman is young, she has a lot of receptors to FSH and LH and has normal hormonal level. Very little amount of inner LH is enough. But when woman became more later productive age, after 35 years old, the number of LH receptors decrease, sensitivity to FSH decrease, and in this case, we need a little bit different amount of hormones. And in this case, only FSH sometimes is not enough, or enough to follicle growing, but not enough to good egg maturation.
Thank you once again for interesting question and your answer and explanation to that. And Marie has another question. First IVF failed with 2 eggs retrieved, none was fertilized. It was a long protocol. My AMH is 1.4. Should I get a short protocol for the next IVF? I am 40.
As for me, probably it will be good option, but first necessary to see if IMH 1.4 is real, if it is correspond to for example, 7, 8, 9 antral follicles, because with this amount of IMH should be more or less 7, 8, 9 follicles. If, for example, we can see only 2, 3, it means that IMH level is not done correctly, laboratory on some pre-analytic or some other problem, and we can expect only few number of eggs. But if we can see a lot of follicles, much more than 2, in this case necessary to or use another medication like FSH plus LH or increase the dose, or probably, as for me, better option will be the short protocol, but necessary to see all these things before to understand which tactic will be the best.
Okay. Thank you once more for that. And another question from Sebastian. What would you do after stimulation with empty follicle syndrome? Which stimulation protocol and which embryological techniques?
Thank you for this question. So, empty follicle syndrome, no eggs. So, first of all, necessary to understand if it is error, mistake, or it is a real problem. To understand that, necessary to see the day of egg retrieval. If you has done Hcg triggering, necessary to take blood to Hcg and progesterone. progesterone should be high if your injection was done correctly, and Hcg should be around 40, maybe 60 units. Even you can do the very simple things to do the pregnancy test. If your injection was done correctly, pregnancy test should be positive. Also, what can happen with Hcg injection? For example, your egg collection is Wednesday and your triggering is Monday evening. But sometimes patient, how to say, mixed dates and may do the injection, for example, not Monday, but Tuesday evening. And the next day, patient come for egg retrieval, and it is not 36 hours, but like 12 hours. And in this case, of course, we will have empty follicle syndrome. You will have high progesterone level, and you will have high Hcg level in blood, but not enough hours for final egg maturation. Yeah, and in this case, necessary to repeat egg collection in one day. If it if it was triggering with agonists of GnRH, the same, necessary to control the next day, 12 hours later, ovulation test or blood test. LH level should be more than 12. If more than 12, should be normal egg maturation. If less than 12, it means that or not act correctly, or, for example, some technical problem. In this case, if technical, okay, in next stimulation necessary to do correctly. If all tests are correct, number of follicles correct, duration of stimulation is minimum 9-10 days, we can use double triggering, Hcg and then agonists, but Hcg 40 hours before, because individually sometime egg may become mature a little bit later. Normally, it is the maturation of eggs start after 32 hours after triggering, but sometimes it is 35, sometimes it is a little bit more, and in some individual case it is 40 hours. So also we can do that. Also, we can use the technique of flashing. So we aspire follicle, then put inside some specific liquid like washing and take out. And after 2-3 washings, sometime we receive egg. Okay, RCT say that washing will not improve dramatically the live birth rate, blah, blah, blah. But if we have 10 eggs, okay, extra more probably will not change a lot the situation. But if we have only one follicle, of course, if we receive egg, it will change the situation.
Brilliant, thank you. And actually, Marie has added additional information here. The previous patient, I have endometriosis, and I am 40. Does endometriosis impact the ovarian reserve? My MH is 1.4.
Yes, of course, endometriosis impact the ovarian reserve, but in this case, IMH will drop down. It means that if you have endometriosis cyst in ovary, the amount of normal follicular tissue in ovary will decrease and your IMH should drop down. So endometriosis will not produce higher IMH than it is in reality. It may really decrease ovarian reserve, but in this case we will see simultaneous decrease of anti-Mullerian hormone level.
Understood. Thank you, Marie, for that. I hope that was helpful for you. There are a few questions left, so slowly we will be finishing. Sorry, but of course there are some questions that we want to answer still. Do you recommend to transfer on day 3 when you have a poor responder or advanced age with few oocytes?
A very good question. Thank you very much. There is some Cochrane database recommendations. Then if you have only 1 or 2 eggs, 1 or 2 embryo and advanced maternal age, it is slightly better to transfer at 72 hours, slightly better results. But from the another hand, when we transfer 72 hours, we don't understand the situation. For example, if we don't know if this embryo go till blastocyst stage or don't go, and in this case, no chance that it is implant. When we transfer blastocyst stage embryo, as minimum, we understand that it is either the problem of embryo or either the problem of endometrium. Yeah. If we have nice blastocysts, okay, we are searching some implantation problem. But if we have no blastocyst, we understand that whatever we will do with endometrium, nothing will happen.
Thank you indeed for that. And let me have a look. Okay, next question is here. It was really informative. I'm 38 and just went through IVF process. 17 oocytes and 13 matured eggs were fertilized and 7 embryos frozen. Is this a good outcome?
Yeah, it's quite good, quite good. 17 oocytes and 13 mature eggs. I don't know, not mentioned the result of other 5 oocytes. It may be GV, it may be degenerated, but it is quite good. 13 mature oocytes. 7 embryo frozen, it means that probably 7 blastocysts, and it means that around more than 50% of blastulation, it is rise a very good result. Necessary, of course, to see the morphology of this blastocyst, but it is normal.
All right. Thank you so much for sharing. And of course, best of luck, okay, to everyone, obviously. But thank you indeed. And as you can see, some thank yous are already coming in for you for helping out with the questions. So thanks a lot. Well, next
You're
question.
welcome.
It's a long question. There are lots of details and there are two parts of it. So let me go to the first part.
Mhm.
On 48, AMA 0.47, AFC 68. I had dual stim short protocol for my ninth and 10th egg
Okay.
retrieval.
Mhm.
We used Pergoveris from CD2, and my baseline was FSH6, LH4, estrogen 0.016, but progesterone was 5. We used single trigger, gone up till 0.2. We got 7 follicles on good size, and for the first time, 4 follicles were empty. From 2 egg, 1 was mature and made to 4 AA blastocyst. Can high baseline progesterone has anything to do with poor response? Let me go to the second. For the 10th egg retrieval a week ago, I got my period after 5 days break. Baseline test shows all good numbers. I asked for double trigger and femur 5 milligrams.
Mhm.
Pergoveris 150, Menopur 75. Finally, for the first time, I got 6 eggs, but we were triggered on day 9 because my clinic do not work on weekends. So 2 eggs were not mature. The other 4 all fertilized with ICSI and 2 managed per day per to date. Day 4 and good chance to
Mhm.
make it to day 5. I will go to the previous part.
Yeah, so the main question is, as I understand, if high progesterone may influence the quality of response. Yeah.
I believe so, yeah.
As for me, not a lot. In most of publications now, it is written that should not influence. And now a lot of protocols propose to do without antagonist, without agonist. It means that stimulation and at the same time with progesterone, because progesterone prevent spontaneous LH increasement, spontaneous ovulation. So normally should not influence, but of course it may be due to a lot of different things. For example, this way of follicle growing may be like that, not very good, for example, yeah, because some cohorts of follicles may be better, some may be worse. Also may be due to single triggering, because sometime when we add Hcg to agonist, it may increase the number of mature eggs. So it is rather the problem of triggering, of dosage, of duration than of progesterone. And also now a lot of clinics start to do the stimulation protocol from second phase of cycle, and we are doing as well, and especially for egg donation program for egg donors. We are not waiting, we start when they come, and we don't see the big difference between the egg quality.
Okay, and sorry, Shadi has one more thing to add here. I had 8 egg retrievals and never get more than 1 egg fertilized, made it to an embryo. I live in Norway and they do not do baseline blood tests. And now, after sixth cycle, I insist on baseline blood tests. No, I noticed even my progesterone is over 3. They just run the cycle, and from 6-8 AFC, I never get more than 1 egg to embryo. From the last recycle, as my progesterone was very high, so they were no fresh, I managed to bank 3 embryos. Do you have any experience with dual stim protocols? I had 6 embryo transfer that failed. Now going to do an ERA test to find my receptive endometrium, I guess. And I always made nice blastocyst. Any suggestions?
About dual-stim protocol. So yeah, we are doing quite often, especially for foreign patients, because they come for short period of time. They cannot stay very long. So we try to do, how to say, do stimulation during the one menstrual cycle, and sometimes second stimulation working better than the first one. So it is the good option when we have low number of follicles. When you have 6-8 antral follicles and, for example, only one embryo, necessary to see that it is empty follicles or not mature eggs or they don't grow. And in all these 3 cases will be different approach. If, for example, we can see 8 follicles and growing only one, and each protocol you receive the same dosage, probably necessary to increase the dosage. If they all growing and at the end they are empty, probably trying to do double triggering, or for example give more hours after the triggering and retrieval. If, for example, receive 8 eggs and, for example, all are immature, probably try to in vitro maturation. So necessary to see the little bit in details.
Thank you again for lots and lots of details, Shadi. I hope that that was helpful, and I believe it was okay, because there is actually a comment and a question. Thank you so much for response to all my questions. Could I do another dual stim right after the first time, or I should wait?
Look, we can do the dual stim protocol only in case if the first protocol, first retrieval and first triggering was with agonists. And in this case, in today, normally all hormones drop down and we can start the second stimulation. But if your triggering was done with Hcg, necessary to wait as minimum 10-12 days, because your ovary will not be sensitive to stimulation. Hcg will, how to say, occupy all receptors and it will not work. So dual triggering, dual stim is possible in case on if first will be with agonists.
Okay. Thank you so much. Indeed.
You're welcome.
Excellent. And there are like 2 questions, so I guess we will be finishing with those. Sebastian has another question here. In double triggering, do you give GnRH 36 hours before oocyte retrieval?
Depends. Some patients, especially late reproductive age and decrease ovarian reserve, may have the tendency to earlier spontaneous ovulation. So better to do 35 hours or even, for example, 34. So necessary to see case by case. But in some patients we receive eggs but not sorry, with good maturation. In this case, necessary to do a little bit more. So depends on situation. If it is normal responder and nothing special we can found, it is 35 around hours.
Thank you for the confirmation here. Let's have a look. Might be our final question. So, why is the cycle after the stim cycle so long? Mine is at least 10 days longer than usual.
Thank you. This is the interesting question, but it is normal that it is like that. So it depends also on triggering. If your triggering is agonists, normally your cycle will arrive in 4, 3, 5 days quite quickly. But if your triggering was Hcg, as we have seen, Hcg stay in blood circulation 10, 12 days. So before your Hcg will disappear, your ovary will still actively produce hormones, progesterones, and menstruation start when your progesterone drop down, and progesterone will drop down when your Hcg will drop down. So your cycle after Hcg triggering may be like 2 weeks later, something like that. You're talking after. Okay, this is because your ovary need time to restoring hormonal activity. Because menstruation start when there is a difference between progesterone. Progesterone, if you have the big stimulation, will not drop down very deeply. Yeah, so necessary that your corpus luteum disappearing, then start growing the new follicles, and these take a little bit more time than a normal cycle. So the cycle, next cycle after bleeding, after stimulation, normally is longer than your standard cycle, and it is more pronounced, more, how to say, high response you have.
Brilliant. Thank you once again for the explanation. As I've mentioned, that was our final question for tonight. So thank you, everyone, each of you, for your questions, for staying with us a little bit later. And it was great to have you back, Dr. Halyna. And I will show you some comments in a second because they are definitely brilliant, and patients are very, very satisfied with your presentation tonight. And of course, with all of your help. As you can see, fantastic presentation, Q&A session, detail level is credible. Thank you very much. Cannot agree more here, definitely. Great presentation, and more thank yous are coming in right here. So huge thanks. Glad that you are back with us. And let me just, before we finish, let me just add that Dr. Halyna will be back actually next week. We have another webinar with her. We will talk about poor responders. So I guess you can definitely come in and join us next week on Tuesday at 7 p.m. same time. So I hope you will be able to join us, and I'm sure you will find it useful as well. Dr. Halyna, as always, it's great to have you. I hope you are satisfied as well, and anything else you wish to add before we finish.
Thank you very much. It was really interesting. The stimulation protocol, this is my more, how to say, favorite topic. I like it very much. So I like your
We can
questions.
see that, I think. We can see that. So thank you so much. I do hope that you will feel much better, because you don't know, but actually Dr. Halyna is actually a little bit sick. She got COVID, but I hope that you will feel much, much better very, very soon. So all the warmest wishes I'm sending, and I guess everyone. So thanks so much
Thank
for, still being with us. And of course, we will see each other next week. And okay, yeah. I'm sorry, just one more thing from others' questions as well. Great. Thank you so much for that comment. Because I think this is the case. Sometimes other people questions can actually make you wonder and make you a little bit more intrigued, or maybe, you will ask some more questions because of that. So this is how it works. Thank you so much indeed. Remember, it has been recorded. You will have a chance to watch this tomorrow if you missed any parts of those. And myivfenses.com, this is the website you can go to if you want to see the previous webinars or if you want to have a look at some of our upcoming events. Thank you so much, everyone. Dr. Halyna, see you next week. And I'm already looking forward to it for sure. Thanks so much indeed.
See you soon.
See you
Have
soon.
a good night.
Have a good
Bye
night,
bye.
everyone. Bye. Take care.